Hello everyone, welcome back to my YouTube channel Dr.Barki's Ophthalmology Tutorials. First of all, I am sorry for not posting videos in the last 1 or 2 months. I got really busy with the practical examination, paper evaluation and hospital work as well as my personal commitments. So I could not post the videos in the last 1 to 2 months. I am really sorry for that. And as you all know, in the CBME batches, they are asking questions based upon the case scenarios. Okay, they will give a case scenario and they will ask you to make the diagnosis, then describe whatever they are asking. So it's very important to make the exact or the correct diagnosis in a given case scenario. Otherwise, you will miss the whole question. Okay, so I thought of discussing some of the case scenarios of the leucocoria, like how to arrive at the different diagnosis based upon the case history. Then we will discuss each one. Okay, so here is a case scenario like a mother comes with a 9-month-old baby with complaints of the whitish discoloration in the center of the eye, that is right eye. She also gives history of premature delivery of the baby at 28 weeks. Birth weight was 1300 grams. Mention the differential diagnosis for the above condition. What is the most probable diagnosis, and explain in detail about the pathogenesis, clinical features and the management of the same. So like this, the question can be asked for your main question or even the short notes. So here you have to analyze the history what they have given. So mother comes with a 9-month-old baby. The age of the baby is also important. Complaint is whitish discoloration in the center of the eye, that means in the pupillary area. So you should think of the leucocoria as the main diagnosis. So then comes the differential diagnosis for the leucocoria and see for which this history can fit into. So before going to this case proper, let's see the differential diagnosis for the leucocoria. So it is must to know the differential diagnosis for the leucocoria or the white pupillary reflex. Not only for your examination, but it is very important as a clinician to know about the DDs for the whitish reflex at the pupil. Even the pediatrician should also know about the importance of the white pupillary reflex, and they should examine the pupil of the newborn. And if there is a white pupillary reflex, they should send to the ophthalmologist, because it can be sight threatening and even it can be life threatening sometimes. So these are the DDs. The first is the retinoblastoma. Then comes the retinopathy of prematurity or ROP, congenital cataracts, persistent fetal vasculature syndrome or persistent hyperplastic primary vitreous, Coats disease, diffuse choroidal hemangiomas, endogenous endophthalmitis, Toxocariasis and Norries disease. So these are the different causes for white pupillary reflex. So now let's see with the history how we can rule out each one or come to the diagnosis of the same. So the first DD is retinoblastoma. This is one of the most common pediatric solid tumors. So the age of presentation depends upon which type of retinoblastoma it is. If it is of inherited type, that is familial retinoblastoma, then it usually appears in the first year of life and most commonly it is bilateral. If it is sporadic case, the age of presentation may be 1 to 3 years. So here the catch point is you should ask for the family history. Most of the time it can be positive family history, or in the case scenarios they will mention it as with a family history of similar complaint in the siblings or the family members. Then you should think of the retinoblastoma, and it affects both boys and girls with the equal frequency. That is the hint in retinoblastoma. So how will be the case scenario in the case of congenital cataract? The congenital cataract can be either unilateral or bilateral. Here usually the child or the parent comes with the poor vision since birth. Sorry for the spelling mistake. Usually the parents come with history of poor vision since birth. And if you dig into the history, the mother may give history of torch group of infection during her pregnancy. That is history of rashes or fevers during the first or second trimester of pregnancy. Then you should think of congenital cataract. Then we have persistent hyperplastic primary vitreous. It is uncommon congenital ocular anomaly where there is persistence of the hyaloid vasculature system or the primary vitreous fails to involute. Then there is the condition known as PHPV. Usually it is sporadic and the hint here is associated with a small eyeball. In other cases the eyeball size is normal, but here the eyeball may be small, that they may mention in the history. And it is usually associated with other ocular or the systemic anomalies like microcephaly, or there can be mental retardation, spasticity, cleft palate, short stature, or even the megalocornea. Again, there is no sex predilection for this PHPV. The next DD is the Coats disease. It is nothing but idiopathic condition which is characterized by retinal vascular changes and the exudation. Here the catch point is again it affects boys more than the girls. So in the history they may give or particularly mention that the boy or the male child is affected. It affects boys in the ratio of 3:1. It is unilateral in presentation most of the time, except only in 10 to 15% of the cases it can be bilateral. Usually the average age of presentation is 8 to 16 years, though it's congenital. So if the children are suffering from the Coats disease, they usually have poor vision and the strabismus along with the Coats disease. So these are the catch points for your Coats disease. Then coming to diffuse choroidal hemangioma. Again this is nothing but a benign vascular tumor of the choroid. Again very uncommon with equal incidence in both males and females. Though it's congenital, again it's detected usually in the 2nd to 4th decade of life. So the history will change, like the patient may be presenting in the 2nd or 4th decade of life, and it is usually a part of Sturge-Weber syndrome. So we'll have other features of the Sturge-Weber syndrome like the facial nevus can be present. So this white pupillary reflex is most of the time unilateral, which is present on the side of facial nevus. Okay, so this is the history in case of diffuse choroidal hemangioma. The next DD for your white pupillary reflex is Toxocariasis. So whenever they give this case as your question, they usually mention that there is an history of contact with the pet animals like dog. Okay, and there is more marked inflammation of the eye. The eye is usually inflamed along with the white pupillary reflex, and the age of presentation is around 2 years. So these are the catch points, that is history of contact with the pet animals, markedly inflamed eye along with the white pupillary reflex, and presenting in around 2 years. Then we have endogenous endophthalmitis as one of the DDs. So here the patient may be having endocarditis. So the patient will have the features of endocarditis and infection in the GIT. Usually the causative organisms are like staphylococci, streptococci and even the fungi. And here the patient presents with poor vision with floaters. Okay, so this is one more symptom which they may mention in the history, and it can be again unilateral or bilateral in presentation. Next, the last DD in our list is the Norries disease, which is usually X-linked recessive. Hence, it affects only boys. Okay, the females will be carriers. Usually, they present with congenital blindness, which is there since birth. Most of the time, it is bilateral, and they will present with white mass in the pupillary reflex. So, these are the various DDs for white pupillary reflex. So, let's come back to our question. That is, mother comes with a 9-month-old baby with the complaints of white pupillary reflex. She also gives history of premature delivery at 28 weeks and birth weight less than 1300 grams. So these 2 points are more than enough to make a most probable diagnosis as our retinopathy of prematurity. So we have answered this part of the question, that is differential diagnosis, and the next question, that is the most probable diagnosis, is the retinopathy of prematurity. So explain in detail about the pathogenesis, clinical features and the management. So the diagnosis is ROP, that is retinopathy of prematurity. So I will be discussing retinopathy of prematurity under the headings of introduction, definition, pathophysiology of ROP, classification, risk factors for retinopathy of prematurity, examination techniques, prevention and treatment. This is most frequently asked main question as well as short note question, and everyone should know about this ROP. So coming to introduction of ROP, this condition was first described by Terry in 1942. He was both ophthalmologist as well as pathologist. He observed in a 6-month-old baby a greyish white vascular membrane behind each lens. That is, in both the eyes he observed some greyish white membrane behind the lens. So he thought it could be retinoblastoma, and the enucleation was done for one eye. And after histopathological examination, they found out that the retina was incorporated in the fibrous tissue behind the lens. Hence, it is also called as retrolental fibroplasia. But later, they found out that the ROP goes in various different stages, and this is the last stage where the child can have retrolental fibroplasia, and hence they renamed the condition as retinopathy of prematurity. So coming to the definition of ROP, so retinopathy of prematurity is a vasoproliferative retinopathy which occurs principally but not exclusively in the premature infants. Though premature infants have high risk of developing retinopathy of prematurity. Even the mature infants can also develop ROP in some conditions, which I will be explaining later. In the next video, I will be explaining about the various other aspects of the retinopathy of prematurity. So hope this video is helpful to all of you. If you like my videos, please do subscribe to my channel. Press the bell icon for further notifications. Please do like and share my videos. Thank you so much.